Okay, so we're going to have a presentation from Dr. Robin Lachmann. He's going to be discussing women with AMN, and afterwards we'll do a quick Q&A session. Okay, thank you.
Thank you. Right, I don't think the audience may have changed, but my slides have not changed since the last time I did this, which was probably last year. So feel free to interrupt as we go along as well. I've been asked to talk about men with adrenomyeloneuropathy. And we do now have some, which you'll have seen, I'm sure, from various other people as well, international recommendations for how we manage the various forms of leukodystrophy that were published a few years ago now. And if we look at the myeloneuropathy bit of things, the first thing they say is that treatment is supportive. So that means actually, at the moment, we don't have anything we can do that changes the natural history of that part of the condition, unfortunately. And the majority of men with an ALD mutation will at some point develop some spinal cord symptoms, although, as you may have heard yesterday, the more we do with newborn screening and looking at the genetics, the more we're finding mutations that perhaps don't actually cause disease. But if you've got a mutation that causes diseases, you probably will run into some of these problems as you go along. And the things we have to deal with are pain, which is often due to nerve disease, the problems with walking, the stiffness of the legs and the weakness of the legs, the spasticity, and the bladder and bowel issues, which fortunately Sarah's already spoken about next door, so I'm not going to have to do much about that because not my area of expertise. And I should actually put my hands up to self and say I am not a neurologist. I look after metabolic diseases. A lot of those have neurology to do with them, but I do rely on my neurology colleagues to look after aspects like the bladder and the spasticity. Okay, so if we start with spasticity, so clinically, that tends to start off with people noticing their gait, maybe a bit clumsy, tripping over things, other people commenting on it. And then you develop stiffness in the legs, spasms, weakness, and can end up needing walking aids and things. And this is due to problems not in the muscles of the legs themselves, but in the spinal cord, in the nerves, if you like, within the spinal cord. So your muscles are controlled by neurons that sit in the spinal cord directly, but those in turn are controlled by other neurons that sit in the brain. And it's the connections between those neurons in the brain and the neurons in the spinal cord that directly control your muscles that are involved in myelopathy. Myelopathy is disease of the spinal cord. And in the legs, that leads to spasticity. Clinical features of spasticity, so clonus. What's clonus? Well, the first thing when we come and see us, early on we'll probably tap your reflexes. So those can be quite brisk, and then quite often people notice that if you pull on your ankle, it starts to spasm. That's what clonus is. It's a sort of exaggerated reflex. And you can actually start noticing that in everyday life. So if you bend your ankle or your knee, the leg will actually jerk. That's what we mean by clonus and spasms. So spasms are similar. And then the legs get stiff. You can't actually move them as well as you want to. And can get weak as well in due course. And you end up with a spastic gait, where the legs have because the muscles are stiff, they keep the leg extended and turned in, so you tend to catch your toe and things, a very characteristic way of walking, a scissors gait. How do we treat that? Well, as I say, we can't actually at the moment stop the spinal cord disease, but we can certainly do things to treat spasticity, which is a common feature of a lot of neurological diseases. So you'll see it in many other neurological diseases that affect the spinal cord. And the principles of treatment are to try and make it as comfortable as possible, so deal with pain and discomfort, to improve function, so get posture better, try and make sure that walking in particular, but then later on sitting and standing as well, are as efficient as they can be, and prevent complications like pressure ulcers in due course. Fortunately, it doesn't really get to that point until you're very immobile. How do we do that? Well, I would tend to refer you to our neurology colleagues who are experts in spasticity, but they would use the same sort of thing. So there are drugs you can use, and baclofen is probably the commonest one we use still. And lots of people were being given some baclofen, perhaps particularly in the evening, to deal with spasms and things at night. Baclofen can help with that. It's an it reduces the stiffness, it reduces the spasms, But the flip side of that is it makes the muscles a bit weaker. So if you're actually relying on the stiffness of your muscles to keep you upright, and we reduce that stiffness, then actually it can lead to people having problems being able to keep independently mobile. So quite often, you may have been on baclofen from your GP, because GPs will use that for quite a long time, but when we send you along to see the spasticity team, they'll actually say, let's get you off the baclofen now, because it's being counterproductive rather than productive. And there are some other drugs that do the same sort of thing, so tizanidine, certainly we do see used. It has more side effects than baclofen, probably different side effects. Not so much dantrolene, and gabapentin is used both for pain and for spasticity, so that's something that people occasionally use as well. Botulinum toxin, so that's something that I think lots of people we see get often from their local neurologists. So botulinum toxin deals with spasticity by dealing with the muscles. So if we say that the problem is there's lots of neurological activity coming into the muscle telling it to contract, if you can block that, and that's what botulinum toxin does, if you can block the nerve that's telling the muscle that it needs to contract, then that can actually help with spasticity. It can make the muscle more relaxed, if you like. It can actually paralyze the muscle, and that can be quite useful sometimes, particularly muscles like at the back of the leg, which can be shortened, which means your foot goes down. If you can paralyze that, you get a more normal gait. So botulinum toxin works for a few weeks or months, then it needs to be repeated, and if it's repeated too many times, you'll end up with a paralyzed muscle anyway. Other things that probably don't use so much intrathecal baclofen, so you take baclofen by mouth, but you can also give it directly to the spinal cord where it acts on the nerves with a pump. That's not something we use so much, but you may come across reading about in other places. And then there's lots of non-drug interventions, so lots of physiotherapy, splinting. Unfortunately, in the NHS, getting physiotherapy isn't that easy. So you'll normally get the maximum of 6 weeks if you go and see someone in the community, and then they leave you to yourself. And that's not ideal, but that's all the resource we have at the moment. But exercise and things are important. We certainly try and get people to keep as active and exercise as they can. And then functional electrical stimulation. So I've seen at least one set of functional electrical stimulation. Deirdre's got it on her legs. So the idea of functional electrical stimulation is to improve the function of your gait, if you like. So as we said, one of the problems was that the muscles at the back of the calf can pull the foot down, and so when you walk, you catch your toe and can trip. And the idea of functional electrical stimulation is to try and actually, as you're pulling your leg through, directly stimulate the nerves to that muscle to make the foot come up again, so you can actually pull the toe up. So there's a little box that sits on the hip, and some wires that go down here onto the nerve. The box works out when you're pulling your leg through and actually tries to pull the foot up, and that can be very useful actually in improving function. So the Botox in the calf will paralyze that muscle, so it can bring but that isn't coordinated when you walk so much. Would that be, I've got neurologists in the room. Sarah could correct me if I'm wrong on any of this. But so what you're doing with functional electrical stimulation is actually getting the muscle to contract and pull the muscle up. What you're doing with Botox is paralyzing a muscle. And that's all the time. So they can both be useful. And if you get to the point where the nerve isn't actually functioning properly anymore, and that's part of adrenomyeloneuropathy as well, then functional electrical stimulation won't work because the signal doesn't go down the nerve to the foot. But that's something that is available, and can be, normally there will be a local service that can set you up with that. And then mobility aids, so I think are very important. They range from a stick to a crutch, to a chair to a scooter. They can prevent falls, that's very important. Obviously, falling and breaking a leg or something that makes you immobile for a long period of time, and often you won't get back to where you were before, so it's important to prevent falls. But they also actually help maintain independence. And one of the issues with mobility aids is people don't like to start using them because they think It makes you look as though you're disabled and you don't want to do that. But actually, if it lets you walk around more easily, particularly with a buggy, if it lets you get from A to B easily and quickly, then there's much more time to do what you want to do when you get to B. So I always think people are far too reluctant to start using things like scooters. People may disagree with that, but... So that's the spinal cord side of things. So then the peripheral nervous system is when the neural connections, the axons get outside the spinal cord, they get into nerves, and nerves are responsible for both taking information from the brain to the muscles, for instance, to make them contract, but also bringing information back from the skin and indeed the muscles to the brain to tell you sensation, so what you can feel, but also if you're standing on something hot or if you're standing on something sharp. They also tell the brain where your legs are, so something we call joint position sense. So actually there are nerves coming back up that tell the brain whether your knee's bent, whether it's straight, where your foot is in relation to the rest of you, and that's all very important in working as well. So there are both afferent nerves, those are nerves that take information from the periphery, from the skin and the joints to the brain, and efferent nerves that actually take the instructions from the brain back out to the periphery. And these nerves, again, mostly in the legs, or particularly in the legs, only in the legs, can be affected and can affect both of those directions. So there can be problems with sensation, so numbness in the feet, not being aware of when there's pain, or when you're treading on something, and also the brain not being aware of where the legs and feet are and what they're doing. And so some of the most important problems with peripheral neuropathy are this lack of sensation, which means you're much more likely to damage your feet and not know about it. So a small cut on the foot can turn into an ulcer if you're not actually aware of it. You can also get pain, neuropathic pain. So although you don't feel pain when you're supposed to, conversely, it can be painful all the time when it's not supposed to be painful because the nerves are not working properly, and that can be a difficult thing to deal with, and again, drugs can come in there. And it may also increase the risk of falling because your body doesn't know where your feet are. So how do we manage that? Well, foot care is extremely important, and we try and recommend that people have proper chiropody. Probably best to have someone professional cutting your nails and looking after your feet than trying to do it yourself, because if you cut yourself, you can end up in trouble. The neuropathic pain we've just talked about, you can treat that with agents that can help with reducing the pain sensations, if you like, coming up from the periphery, so things like amitriptyline, pregabalin, gabapentin, and at the end of the day, pain clinics can be quite useful for that sort of thing. And again, falls prevention, things like using walking aids, crutches to make sure you're not falling. The bladder, so that's nerves again. So we talked about the nerves to the feet, there are also the nerves to the pelvis. I'm not going to have to say very much about this, I hope, because Sarah covered it next door, and I think we're doing a session this afternoon anyway, so I'm sure if you have any questions about the bladder, you can ask there. But as you heard, the problems here tend to be that the bladder is irritable, overactive, prone to contract without you necessarily wanting it to, and so the problems we see are urgency, having to rush off, frequency, having to go more often than normal, and urge incontinence, not being able to make it in time. And there are drugs and other interventions, eventually self-catheterization, that can deal with that. So that's sort of a quick go through the neurology of adrenomyeloneuropathy. We've dealt with the myelo bit, that's the spinal cord, and the neuropathy bit, that's the nerves. The adreno bit is the adrenal glands. Adrenal failure is definitely a part of all forms of adrenal leukodystrophy. It is something that you're at risk of throughout life, but once actually, if you haven't got adrenal disease by the time you start developing significant myelopathy, you're less likely to get it. Not impossible, but less likely. So it's something that tends to come on quite early on, or much, much later on, but less likely. But it's important to keep an eye on it, and we'll certainly, when we see people do a blood test, to check the levels, actually not of the hormones from the adrenal gland themselves, but the hormones from the brain that control the adrenal gland. Because if your adrenal gland isn't working properly, your brain works that out, and it starts to produce, it tries to drive them hard, and there's a hormone called adrenocorticotropic ACTH, the trophic hormone, which is what the brain drives the adrenals. And if the adrenals aren't working, that goes very high. So the first screening test we do is to look for a high ACTH. And if it is high, then we'll do something called a Short-Synapton test, where we actually measure the ability of your adrenals to respond to ACTH. And if that's not good, then you need steroid replacement. And I think that's been talked about quite a lot today. So that's sort of the symptomatic management of the features of adrenal leukodystrophy. How am I doing for time? Well, not too bad. We'll try and get back on track. So then the other issue that people rightly worry about is not the progressive, slowly progressive spinal cord and nerve involvement, but the risk of actually developing cerebral disease later on in life. So undoubtedly the most frequent time for males carrying an ALD mutation to develop cerebral adrenal leukodystrophy is around the age of 6, 7, early childhood. But it can happen later on. And it can happen in men who've already got adrenomyeloneuropathy. It tends to be a bit different, tends to be a bit more slowly progressive. But it is something that can be devastating and can shorten life. So on that basis, we can screen for it using MRIs in the same way that is done with boys. We don't do it quite as often in adults. We'd ideally be doing it once every year or so. This isn't something we used to do routinely in the UK because there wasn't anything we were going to be able to do about it if we found something. That's changed now. We can now do bone marrow transplants for any age if people develop cerebral adrenal leukodystrophy, providing that the patient's fit to have one. And therefore, we have moved to trying to make sure we do get annual MRI scans in men with AMN who would be suitable for bone marrow transplant. Who's that? Well, as long as you're mobile, and as long as you're not actually having to self-catheterize, then you're probably potentially a candidate. The problem is if you're wheelchair-bound, or if you're frequently having to put a catheter into your bladder in order to drain the urine, that means that you're at risk of really serious risk of increased risk of infection. So with a bone marrow transplant, we wipe out your immune system, give you someone else's, but it takes time for that to grow back, and there are a few weeks when you're actually at high risk of infection anyway. If we combine that with the not being able to move around and the risk of skin sepsis or the risk of bladder sepsis, the experience has been that that's actually very bad, and the outcomes are very bad. So there is a point, there will be a point, when we say, actually, I'm afraid the myelonopathy is too far advanced that you wouldn't be a candidate for bone marrow transplant anyway, and at the moment, we'll talk about this a bit more later, we don't have anything else to offer. But certainly for younger patients and patients with less disability, we should now be scanning with the basis that if we pick up early changes, we should be able to offer some sort of treatment, or at least the option of some sort of treatment. And that's just an idea. We've seen lots of that this week of what adrenal leukodystrophy looks like. We've talked about the fact that it's bone marrow transplantation that we can offer. There's no gene therapy available for adults, that's only available for children. So take-home messages: stay mobile. Try and keep mobile, keep flexible. Gym, exercise is all a good idea. Use aids when you need them, try not to fall. And try and treat symptoms before they become a major problem. So that's why we like to see people on a periodic basis regularly so that we can actually ask about symptoms. If symptoms are occurring, try and make sure we treat them before they become too problematic. I was going to stop there. I'm happy to